Good afternoon. Thank you, Mr. Chair, members. My name is Eduardo Martinez. I work for the California Medical Association. Pleased to be with my colleague here with the Primary Care Association to present to you this proposal. We had a little bit of late-breaking news on this. We took the Chairman Thurman's direction to heart with respect to working collaboratively on issues of similar interests. And so what we've done is modified our proposal somewhat to incorporate our initial funding amount with the California Primary Care Association's specific budgetary requests. So specifically, we are now requesting $82.5 million to be allocated to Song Brown to support the program's goals, with the remaining $17.5 million to be allocated according to CPCA's request as indicated in your analysis. I was just going to take a brief step back and talk about the general nature of physician training and why these funds are important. Typically, in every state, upon graduation from medical school, physicians are required to complete a nationally accredited graduate medical education program, commonly referred to as residency programs. Typically in their fourth year, physicians will begin figuring out what kind of medicine they'd like to practice. After a lengthy interview, students are entered into what's referred to as the match, which is a national system that residency programs and students effectively get matched to their residency program. This is where our funding proposal comes into play. There's numerous studies which stress the importance of the location of where a physician does her residency training, particularly about where the indication of where that physician is going to practice over their career. In a lot of ways, this makes a lot of sense, right? You have physicians in their mid to late 20s. They begin to earn a salary. They plant roots around their program and such. They ultimately stay in practice there. Regrettably, we're not doing enough to solve the problem of inadequate funding for residency training. While most of the funding typically comes through Medicare, the number of residency positions funded through Medicare has been capped at 1996 levels. And this cap has actually advantaged many East Coast states whose population has declined at the expense of growth states like ours. So that's why this funding request is particularly important. We obviously still have large areas that are dealing with physician shortages, particularly primary care physician shortages. 2014 report by the California Healthcare Foundation found several regions in the state that are not meeting the nationally recognized benchmarks for primary care physicians, most notably the Inland Empire, the San Joaquin Valley, and the Northern Sierra regions. And so this is why we think the Song Brown program is really critical to this. One of the missions of the Song Brown program, of course, is to fund residents in medically underserved areas. So we'll really work to target this money in the areas with the greatest need. It's also important to realize that this funding is not just to increase our overall physician supply over the longer term, but will have an immediate impact on access to care, as of course residents are treating patients immediately as they learn. So, and according to the California Academy of Family Physicians, each additional resident can provide an average of 600 patient visits per year during training alone. So thank you very much. Happy to answer any questions about this request.
Why don't we hear now from the California Primary Care Association?
Good afternoon, members. My name is Beth Malinowski, and I'm proud to be here today on behalf of the California Primary Care Association, teaching health centers. Today we're here not only to support Song Brown, but here to specifically request $16.5 million to develop, expand, and support teaching health centers in California. Teaching health centers are accredited community-based primary care training programs committed to preparing health professionals to serve the health needs of the community through innovative educational programming dedicated to ensuring a relevant and sufficient supply of health workforce professionals. Right here in California, we are fortunate to have 6 of our nation's 60 teaching health centers. And as your analysis points out, over 90% of teaching health center graduates remain in primary care practice, compared to less than 1/4 of traditional graduates. 40% of graduates of teaching health centers become primary care providers in nonprofit community health centers, and this compares to just 2% of traditional medical residents. These statistics paint a clear picture that investment in teaching health centers is the right investment for addressing our primary care shortage. California's 6 teaching health center sites are providing training to over 70 residents today, and with our support, they're on track to be training 100 residents in the coming year. Members of the committee, as Eduardo outlined, now more than ever, we need to invest in our primary care residency programs as they are key to addressing access in underserved communities. With dwindling federal support for current teaching health center sites and no federal investments to develop new sites, California must prioritize a greater investment in the expansion of the teaching health center model. This modest request of $16.5 million will address California's primary care shortage, providing $5.5 million to sustain California's 6 current teaching health center sites and $10 million to establish new teaching health center sites across the state. Additionally, CPCA is asking for $1 million to provide to OSHPED for administration of this new fund. And lastly, CPCA is also requesting the state provide $1 million to the state loan repayment program.
Just a couple of quick questions, and I'll state at the outset, I think I think many of us on this committee understand that we have serious underrepresentation of the physician community in many parts of our state. I want to just get a sense of what you project this money will buy us. So 2014, there was an augmentation of OSHPED's budget, $4 million. Could you tell us how many new residency slots were created with that money, and then can we use that number to extrapolate what we would expect to get for, say, the $82 million that CMA is asking for, the 16.5. Just give us a sense of what you project this will deliver.
Yes, sir. I believe the presentation from OSPED might have covered. I didn't note it, and I don't have it handy. But the $4 million allocation that was
the $4 million added 26 new slots over 17 existing programs.
Okay, so would you anticipate if you got $80 million that it would be 20 times that? That's how many residencies we're talking about?
Approximately. It would obviously depend on the allocation and the types of programs that were involved here.
And what's the need that we're talking about compared to how much? You know, I was looking at the numbers. You need to add another 1,700 to 3,000 primary care residency slots.
Yeah, yes, that's right. And then I also neglected to note, too, that a number of federal and private grants are set to expire or have recently expired that were previously supporting some of Song Brown's efforts as well. So that also has to get factored into the calculation that I can certainly follow up with your office and sort of get you that level of detail.
So if I just did a back-of-the-envelope calculation. With, say, $82 million, if we were to fund the entire proposal, we'd be able to meet about a quarter of the need of what we're talking about. Is that what you're estimating?
That sounds about right, yeah.
Okay. I see we've been joined by one of our colleagues. I want to ask if you have anything that you want to add to this.
Certainly. Thank you, Mr. Chair, committee members. Wanted to come down and lend my support to this request. As a co-author of legislation to try and fuse the Song Brown program with additional funds, I can't tell you how important this is, certainly to rural disadvantaged communities like the one I represent in Merced County and Stanislaus County, where we have a entirely inadequate access to medical professionals. And in an effort, there's just no more effective, proven way to bring physicians to the area than through these types of residency programs. They're underfunded. They've lost funding. I think it's a critical time that we address this. And frankly, the efforts of this body and the efforts throughout the country have been focused on coverage so heavily, and that's a good thing. But handing someone an insurance card when they can't see a physician is like adding insult to injury. It just is not particularly helpful for some of us in some of our areas. And I think we can do a lot of good with this money as proposed. So strongly would encourage your consideration.
Great. Thank you. Unless there are other questions from the committee? Mr. Bonta?
I just want to share my support for this bold and needed request, and I want to thank Assemblymember Gray. He and I have had many conversations about access to care and some of the unique problems he has in his own district, and this is something that can help. These are proven programs, proven effective, helping our disadvantaged communities, helping with our physician supply challenges, and making a difference where we really need access to care that's culturally competent, if necessary, in language. These programs do that, so I'm very supportive, and thank you for the proposal.
I'll just add 20 years ago when I was studying healthcare policy in graduate school, this very issue of underrepresentation, particularly in our more rural communities and underrepresented communities, has been a long-time conversation, and we as a country and certainly as a state haven't figured out how to get it right. So again, as I said before, I'm very supportive of moving forward with something. I think we have to figure out through the budget process whether it's $82 million or what that number looks like. But that being said, I see there are a number of folks here for public comment. I'd like to recognize them.
Thank you. Jody Hicks, representing the California Academy of Family Physicians. And just by show of the coalition that we've put together for this issue, just trying to show how much of a priority it is for everyone on the letter. And just quickly to bring up a couple of points. First, we have been pleased and proud to support the legislature on some of the work they've done on healthcare, including expanding Medi-Cal, including funding new medical schools. And now we're at a point today where we are graduating more medical students than we have residency slots for. So we're investing in having enough medical students, and then we're sending them out to a different state to do their residency program. And statistically, we know that especially for California, because just like anybody else, everyone wants to live here and work here. There's a 70% chance of where you do that training program is where you'll stay, and because you start treating patients immediately. So you're working and treating patients and putting roots down, and that's a 70% chance that you're going to stay and work there. So when we're shipping those students out of state, we're not going to get them back, and that's just a loss to the investment that we've already made. And then just to stress quickly, the $43 million is the amount that we're losing in Song Brown this year due to grants. So asking for $82 million is really supplementing first so that we don't lose those slots, and then putting an additional investment so that we can expand. And we really think, again, we were happy to support and work with the legislature to expand Medi-Cal and to do all the things that we've done. And now we need to find enough physicians to take care of them. So very supportive of this investment. Thank you.
Ms. Hicks, could I ask one question to you based on something you said? I've heard about this disparity of the number of medical students we're training versus the fewer number of residency slots. And given that we do have within our control with some of our public institutions the number of medical students versus residency slots, has there been a conversation among the community if we can't solve the whole problem of trying to balance that a little bit? Does that, my question make sense?
So I think so. Some of the communities will get together and try and start their own residency programs. That does happen. It happened in Fresno. I don't know, Abinaya, if you have anything to add. I have a policy person from our organization, but there are communities that will rally together and try and raise funds at the local level to try and either keep a residency program that's leaving or try and expand it in a few slots. We also know what happens sometimes is you have a medical student that might have wanted to go into primary care. So what they do is they put down their priorities of where they want to, which slots they want to go to. So they might put down California, someplace where they grew up, say, as a number one priority in primary care, but they'll put as a number two priority a different specialty here in California so that they can stay. And sometimes they'll get matched there and they may stay in California, but it's not in primary care, not what we would have liked to do the physician shortage, or they so badly want to be in that specialty they go out of state. So it's difficult, I think, because of the way that the match program works to have really good statistics, but also if we had an abundance of slots, what we know just anecdotally and talking to those students is they would stay in California.
Great.
So.
Thank you. Next speaker.
And just to add on that issue of the question around the number of medical school slots versus graduate medical education slots, the real issue also is that we really need a minimum 40% of our medical school graduates to be going into primary care, and that's really where the disparity exists in the number of primary care slots that exist in California, so that, we have to also push at the medical school level to get students to choose primary care. But when they do choose, if they want to stay here in California, there aren't enough slots in primary care for them. So that's really the issue we're trying to address with this investment.
And I've certainly heard about that. And I would just say to the stakeholders, again, if you have ideas in that area, I would be interested. Next speaker.
Good afternoon, Christina Romero, Planned Parenthood Affiliates of California. We see this as an important program that's recruiting healthcare professionals in communities in need, and those are communities that Planned Parenthood is in, and we strongly support the budget proposal.
Jennifer Snyder on behalf of the Osteopathic Physicians and Surgeons of California. About 50% of osteopathic physicians are actually in primary care, and they actually represent about 40% of physicians that serve in underserved and rural areas. So this proposal to them is extremely important. We feel the Song Brown program has been a very good program, but we're at a crucial juncture with the loss of funding and the need being greater than the funding that's existing right now for primary care slots. So we strongly support efforts with CMA and CPCA and would encourage you to support their funding requests. Thank you.
Chair and members, Barbara Glazer with the California Hospital Association. We too are here today in support of this proposal and pleased to be part of this coalition. Our teaching hospitals have seen their revenues in this area decline over the last number of years, and a proposal like this will lend a lot of predictability, and I think it'll allow these hospitals to maintain and perhaps grow some of the programs they have. Very important proposal for us. Thank you.
Mr. Chairman, members, Randy Perry with Aaron Reed & Associates on behalf of the California Children's Hospital Association. We train a large number of the pediatricians in California, and I just want to stress one more time, the importance of this funding is also to backfill some of the losses. So it's not $82 million or whatever the final number is going to be of new money. Thank you.
Okay, and finally back to Oshpet. I know there has been a question. If this funding were to end, so we move forward with the new residency slots, 3 years of funding, and then it ends, what do you anticipate would happen longer term?
It's very difficult to say. We really aren't in a position to answer that. The funding model that each of the sites have is probably unique to that site, and that would probably really drive whether they would continue in the future.
Okay. All right. Thank you for your presentation. Let me ask Department of Finance or LAO if there are any comments you'd like to make.
Department of Finance has no position on this proposal.
No comment from the LAO.
Okay. Thank you. Thank you very much.
Thank you.
I have been requested by one of our colleagues, Mr. Bonta, if we could move to issue number 19 and take it up under the Department of Healthcare Services, member proposal involving the San Leandro Hospital. Mr. Bonta.
Thank you. Thank you, Mr. Chair, for the opportunity to present this $2 million budget request to help support San Leandro Hospital, which is in my district and operated by Alameda Health System. It's a vital institution serving the needs of my district and residents throughout Alameda County. It's a 93-bed facility, home to roughly 450 employees, 100 physicians, and 40 auxiliary volunteer workers. The hospital runs a 24-hour emergency department, critical care, and a full complement of skilled surgeons, rehab services, and ancillary services to a population of approximately 265,000 people. And like many freestanding hospitals that provide critical services, there have been financial difficulties at San Leandro Hospital. It's faced turmoil, and over the recent years, for a number of reasons, its financial state has become so dire that in 2009, the hospital nearly closed its doors. And given that status, the City of San Leandro and the Alameda County have taken considerable efforts, as has the Alameda Health System, to help keep its doors open. I worked on legislation in the past that helped them align with Alameda Health System and address some of the retirement issues, and that helped. San Leandro and the County of Alameda have also used general fund money. They've taken the very significant step of using general fund money to the tune of $1 million each to help support San Leandro Hospital. And they committed that for 3 years each, and that time is now expiring. So with the $6 million committed and spent, San Leandro Hospital now faces additional challenges. This $2 million budget request would essentially provide an additional year of that same support that together Alameda County and San Leandro City were providing to San Leandro Hospital, and give them another year to help get things turned around. There are some steps being taken now, specifically with now that San Leandro Hospital is part of a system, the Alameda Health System. They'll be moving some of the rehabilitative services from one part of the system to San Leandro Hospital, and that can help with the finances at San Leandro Hospital. So I know that it's not incredibly common for the state to spend funds on a specific hospital, but it's not unprecedented. And when a hospital like San Leandro Hospital provides critical services to vulnerable populations, including a significant Medi-Cal and Medicare population, over 50% of the care is Medi-Cal and Medicare combined, it's important. We have an issue of access to services and a need for critical care services throughout our state, and I'm seeing it right in my backyard, and we have an opportunity to help. So I'm making this request for $2 million and hope for the consideration of the chair on this committee.
Thank you. Let me ask DHCS if you have a perspective on this.
No comments.
Okay. And DOF or LAO? No comments at this point. Any other members of the public that want to speak on this item?
Greg Herner on behalf of Alameda Health System. We just really appreciate the Assemblyman's support for the facility. We, as stated, Alameda Health System took over San Leandro Hospital in 2013. We've put a lot of effort into revamping the operations. We worked very closely with CNA in transitioning that facility and in the legislation that Assemblyman Bonta spoke to before. We are making great strides in adjusting the budget and operations, but we do need a little more assistance to kind of extend us out one more year as we move the rehabilitation facilities over and provide other services in the community and in that facility that will help stabilize the system and keep us going. But we're on a good track, but we really need the assistance to get through one additional year.
Thank you. Other public comment?
Good afternoon, Mr. Chair. Rosanna Carvacho here on behalf of Alameda County Supervisor Wilma Chan, also in support of Assemblymember Bonta's proposal for San Leandro Hospital. As the Assemblymember has stated, San Leandro Hospital is a safety net hospital that serves very low-income patients, and without this hospital, there would be no place for them to go. So we think that this funding request is very important and will help support the continued operation of the hospital's emergency department, as well as assist in the capital's the seismic restoration, help pay for that, which obviously, as you know and was stated in your analysis, is required by the state, and it is a safety issue for all the patients in that facility. That's projected to cost $24 million, and as you've heard, the hospital is barely getting by, so that is a huge amount of money for them. So on behalf of Alameda County Supervisor Wilma Chan, we ask for your consideration of this, and thank you for your time.
Thank you. And seeing no further public comment, Mr. Bonta, any final words?
Yeah, just thank you for the opportunity to present today. This is a one-year request only for gap funding to help get San Leandro Hospital to the next step so that it can continue to operate its critical emergency department and serve the vulnerable populations that it serves, including Medicare and Medi-Cal patients. It's also a really good employer, providing good jobs for our nurses and other medical providers. I respectfully request that the committee consider the one-year request.
Thank you, and we'll obviously do that during the budget process. Thank you to this panel.
Thank you, Mr. Chair.
Why don't we now move to the items under the Department of Managed Healthcare, issue 3. And let's hear first from Ms. Green.
Actually, you're going to hear first from me.
Okay.
I'm Shelley Roulard. I'm the Director of the Department of Managed Healthcare. Mr. Chairman, members, thank you for inviting us to come and present today. I have Marta Green with me, and she's going to go into the detail of our budget proposals, but I thought I would give you an overview of the department before she gets into the specifics. So, as many of you may know, the department licenses and regulates approximately 137 full-service and specialized health plans, providing coverage to more than 25 million Californians. The department regulates more than 90% of the commercial health care coverage market. Our proposed budget for 2016-17 is $78.2 million and 446 authorized positions. I'll just remind the committee that the department is funded solely on health assessments on the health plans. There are no general funds. We also do get a small amount of funding from federal grants, excuse me, and reimbursements. Our main programs, of course, first and foremost is our Consumer Help Center, which is available 24 hours a day, 7 days a week, to assist people who are having trouble navigating the healthcare system, people who have had problems with their health plans, such as coverage disputes or denials of care. We have a team of advocates and analysts that will assist people in resolving those problems with their plans. I should mention first and foremost that the department is a consumer protection agency. Our mission is to protect consumers' health care rights and to ensure a stable health care delivery system. The department also licenses health plans that want to operate in California are required to apply for and maintain a license. We review all aspects of the plan's operations, from networks to financial solvency to how they operate their grievance and appeal systems to ensure the compliance with California law. Our Division of Plan Surveys conducts routine and non-routine surveys of the health plans to make sure that they comply with the Knox-Keene Act and ensure that consumers get access to high-quality health care services. A very important part of our activities are to monitor the financial stability of health plans and medical groups through regular reporting, financial audits, and other monitoring tools. We also review proposed premium rate increases in the individual and small group markets to make sure plans are providing enough detailed information to justify their rates. We also review their annual medical loss ratio filings to make sure the plans are appropriately investing in enrollee health care services. Our Office of Enforcement uses a variety of tools to enforce the law when violations are uncovered. These tools include corrective action plans, settlement agreements, financial penalties, cease and disorders. We can freeze enrollment or, in the most extreme cases, install a monitor or a conservator. You had also asked for some of our recent significant activities. Well, first and foremost, we're dealing with the health care plan mergers that are in the media a lot. We have approved 2. We have 2 that we're still reviewing, the Aetna purchase of Humana and the Anthem purchase of Cigna. Both of those are still being reviewed by our department, and no decision on those have been made at this time. I'm also pleased to report that I believe it's now on our website. The Timely Access Report, Compliance Report for Measurement Year 2014 is now available for the public, as well as all the data that supports the findings that are in that report. Some other major activities for us right now, we're evaluating network adequacy. We recently sent out a lot of letters to plans where there were gaps in their access. We're also gearing up for federal mental health parity compliance, which you'll hear about in a few minutes. And then just general implementation of the bills that were enacted last year, which you also will hear more about. So with that, I'll stop, see if you have any questions, and then turn it over to Marta for the specifics on the budget proposals.
Why don't we go to the budget proposal?
Okay, certainly. Okay, so the first issue on the agenda, issue 4, the End of Life Options Act. This bill authorizes Californians suffering from a terminal disease that meet specified criteria to request and self-administer aid in dying medication for the purpose of ending their life. ABX 215 does not specify whether health plans are required to cover aid in dying medication or how they may decline to cover it. The bill also outlines various procedures and consultations that must be performed and documented prior to the dispensing of aid in dying medications, but does not specify whether any or all of these steps must be covered by health plans. The DMHC is requesting $244,000 for fiscal year 16-17 and 17-18 to address the short-term workload associated with conducting legal research and analysis and promulgating a regulation package. Specifically, the regulation would clarify and provide guidance to health plans regarding the overlap between current Knox-Keene Act coverage requirements and the requirements of the bill.
Thank you very much. Let me ask on these 2 items, Department of Finance, LEO, any comments? Okay, let me ask if there's any public comment on these first 2 items. If not, we'll move to issue 5.
All right, thank you. Federal Mental Health Parity Ongoing Compliance Budget Change Proposal. As a reminder, federal mental health parity required health plans to classify all benefits into federally mandated classifications, such as inpatient, in-network, inpatient, out-of-network, emergency services, and so forth. Once all of the benefits were classified, plans were required to ensure that the financial requirements and quantitative treatment limitations for mental health and substance abuse disorder are not more restrictive than those for physical health or medical surgical benefits. It also required plans to ensure that any non-quantitative treatment limitations apply comparable processes and procedures as those for medical surgical benefits. The DMHC is requesting $529,000 for fiscal year 16-17 and 17-18 for clinical consulting services to assist the DMHC with completing compliance reviews for new plans. These would be brand new entrants to the market or plans that are entering a market segment, such as going from the large group to the small group market segment for the very first time. Based on historical filing patterns, the DMHC anticipates reviewing 28 complex and 125 routine mental health parity filings on an annual basis. There are no positions associated with this request.
Thank you. Anything from Finance? Anything from the LAO's office? Public comment?
Good afternoon, Mr. Chair and members. Tam Ma with Health Access California, pleased to support this BCP. Mental health is an essential health benefit, and patients should be able to access these services without any undue barriers, and we appreciate the department's ongoing work on this. Thank you.
Which one is he doing?
Linda Way with Western Center on Law and Poverty, also in strong support.
Good afternoon, Mr. Chair. Karen Savage, National Alliance on Mental Illness of California, also in support of this item. We recently surveyed our members nationwide on the implementation of mental health parity and still found about a third of individuals living with mental illness are having problems having mental health services approved by their health plans. And so we know this is a continuing issue and appreciate the department's work on implementation. Thank you.
Thank you for all of our representatives from public comment. We're going to make a brief change in the agenda. As you know, members have been coming in and out as we've been presenting bills, and we're in other committees. We have another member who was present who will be making a proposal, and we want to welcome that member. And as soon as we've concluded that presentation, we'll welcome you back to continue the presentations. I just saw Assemblymember Arambula is here. We want to welcome him to present a proposal. We are moving to issue number 22, the Latino Legislative Caucus proposal on Medi-Cal data collection. We are excited to have Assemblymember Arambula here, recognizing his expertise in the healthcare world, Dr. Assemblymember Arambula, and we look forward to the presentation. Welcome, sir.
Thank you.
We are ready whenever you are. If you would like to frame the issue, or if you would prefer for those that you brought to frame the issue and then you give context, we welcome you whenever you are ready.